Good morning, colleagues. I'm happy that you're able to join us this morning. This is a PANCAP webinar on HPV-related cervical and anorectal cancers, looking at prevention, screening, diagnosis, and treatment. I am Dr. Shanti Singh Anthony, the Knowledge Management Coordinator at the Pan-Caribbean Partnership Against HIV and AIDS, and I will be your moderator for today's webinar. Before I begin, let me share with you, I will actually be launching some polls. If you feel free to respond. So while you do that, I will share with you some housekeeping notes. Your mics are muted, and if you have any questions, I ask that you type and you submit these using the chat bar that's on your webinar panel. We will take your questions during the Q&A segment after the presentations. Secondly, we're recording the webinar. The recording will be shared on PANCAP social media platforms for the benefit of those persons who could not have attended this live session that's happening now. But importantly, by continuing to be in the meeting, you're consenting to be recorded. At the end of the session, you will receive a certificate of participation, but you will also receive a post-webinar survey, and I kindly ask that you take the survey and give us your feedback. And we will also email to you at the end of the session the presentations that you will listen to today. Let me go ahead and launch the second. Sorry, that's the first poll. So today we're talking about HPV, cervical, and anorectal cancers. And as you know, cervical cancer is considered a preventable disease. However, in the Caribbean, it still is one of the 4 commonest causes of death in women. Obviously, it is a significant public health issue. But as you would know, in 2019, the Pan American Health Organization defined for the region the Disease Elimination Initiative, which aims to eliminate more than 30 communicable diseases and related conditions by 2030. And so here is an opportunity because cervical cancer is one of those diseases on the list of 30. At PANCAP, we are truly pleased to be able to contribute to the efforts to advance the elimination agenda, and in this instance this morning through knowledge sharing. Thank you for responding to the poll. I'll close this poll and I will move on to the next poll. And while you take the poll, I will introduce our next speaker. And our next speaker is, 1 minute for me. Great. Our next speaker is Dr. Swati Tomar, who received her MBBS from the Dr. MRG Medical University in Tamil Nadu and her MD from the All India Institute of Medical Sciences, where she also did her residency in obstetrics and gynecology. Dr. Tomar is currently an assistant professor, Department of Obstetrics and Gynecology at the All India Institute of Medical Sciences in New Delhi. She is widely peer-reviewed and published and has won several awards for her exceptional work, including the Torrent Young Scholar Award in Obstetrics and Gynecology, the Dr. S. Ponomal Gold Medal in Obstetrics and Gynecology, and the ICOG Dr. Staya Paul Award in 2002 for the Best Original Article. She's involved in course development and training in obstetrics and gynecology and has significant experience in the topic that we're discussing today. And therefore, it gives me great pleasure to introduce Dr. Tomar to do her presentation with us this morning.
Thank you, Dr. Shanti, for the introduction. I would like to share my screen.
Okay, so
are you able to see
it's up. It's up. It is up. Yeah.
So, good morning, everyone. So today we are going to talk a little bit about cervical cancer. And just a minute, I'm just trying to figure out how do I minimize this. Yes. So good morning, everybody. Today we'll talk about the cervical cancer. We will discuss. I am not able to move my slides. Yeah, next. So the outline, we're going to discuss the burden of the disease, pathogenesis, course of the disease, and what WHO has done for elimination call and preventive strategies in short. So when we look at the disease burden, cervical cancer is the fourth most common cancer among the women globally, and it accounts for almost 12% of all the cancers in the women. It is seen that it is the cause of mortality, leading cause of mortality in almost 36 countries. And this is highest in the low and middle income countries, where 80% of the cases are newly diagnosed and mortality happens. So the Globocan 2022 estimated that almost 662,000 new cases occurred in the world, and with 348,000 deaths in the year. So, and this number is estimated to increase to almost 800,000 new cases by 2040. So if we look at the risk factors, we all know that increasing age, early sexual activity, multiple sexual patterns, these are the important risk factors. But the most important and a risk factor is persistent infection with or with a high risk HPV of the genital tract, and this and immunosuppression. So the ladies who are suffering from HIV fall into this group, and we find that these are the groups who have the higher risk of greater lesion severity, multifocal, and also multi-site lesions. So Dr. Harold Rosen is credited to discovery and discovering the pathogenesis of this virus, human papilloma virus, which is a non-enveloped double-stranded circular DNA, and we know that almost more than 150 types have been detected. Almost 40 of them infect the lower genital tract in both men and women. Of these 16 to 18, 16-18 are associated with almost 70% of the cases, and there are 14 high risk cases which are associated with certain other cancers. So what the global incidence of HPV prevalence in among adult women is estimated to be around 12%, and this is highest in sub-African countries, and Latin America, Caribbean regions, and Southeast Asia. Based on countries, the HPV prevalence is ranging between 2 to 42%, and this is highest among the younger age group. But we also know that the women, sometimes when the infection is acquired, almost 90% of them are going to clear of the virus in next 2 years. So the association of HPV and cervical cancer is even seen to be higher than what we know for smoking and lung cancer. And HPV is proven to be a necessary but not essential cause for development of cancer. So there are certain genetic, immunological, and reinfection rates and other factors which have an interplay, and which leads to progression of this infection persistence, and then ultimately leading to cervical cancer. So initially we have a two-tier system, which is for pre-malignant lesions. The low-grade squamous intraepithelial lesion includes a CIN1, which basically replicates HPV infection. But the CIN2 and 3 are considered high-grade lesion with a higher progression rate to cancer. And so this is what we need to target, and we should be able to treat and prevent, because this process from pre-malignant lesion to cancer can even take a decade. So what this HPV does is basically it has 6 early genes. Of these E6 and E7 are important. E6 and E7 respectively inhibits the P53 and retinoblastoma gene, and then cell goes into proliferation. So the basement membrane is infected by this virus, and then it goes and continues upwards, and the disease progresses to the epithelial surface. So with this thing, with this background, with lot of the leading cause of mortality in many countries, WHO made a global call to eliminate cervical cancer in May 2018. It was made by the then Director General of WHO, Dr. Tedros, and in November 2020, the global strategy to accelerate the efforts to eliminate cervical cancer was launched. So it has triple pillars. So the firstly, with the aim is to vaccinate almost 90% of the girls with HPV vaccine by 15 years of age. We should screen at least 70% of eligible women with highly effective test, and at least twice in the lifetime at 35 and 45 years of age, and almost 90% of the women who have a pre-invasive or invasive disease should get appropriate treatment. This is also part of the Sustainable Development Goal 2023. It is part of the SDG 3 as for health, and 5 for gender equality. So this triple strategy is anticipated to cause the elimination, and the target is that we achieve these goals by 2030. Sorry. So as the policy decisions need to be made to improve the cervical cancer program organization, but we as a physician need to strengthen our primary prevention through education, information, vaccination, improve our screening and treatment strategies, and also include innovative strategies. And the main important problem with the low and middle income countries is accessibility. We need to improve the services for cancer diagnosis and treatment for our people. So basically, we talk about the concerns. It is also the women are in resource limited settings. The HPV testing is expensive. Their testing also require advanced laboratory setup, which is also lacking in this part of the world. And also there's lack of public and healthcare provider awareness. There are also cultural and religious beliefs which can also hinder the screening. So we have to address these issues, make this thing accessible to our women. So when we talk about the preventive strategies, we follow the WHO life course approach, where we have the primary prevention, which mainly focuses on the HPV vaccination of the girls aged 9 to 14 years, awareness about the health, and also about warnings about the tobacco use, sexual education, promotion of the barrier contraception condom, since HPV is a sexually transmitted disease. The condom should be promoted. Secondary prevention by screening women who are more than 30 years of age with a highly performant test. And also once we have screened, we should be able to provide the treatment. So this is the life course approach to this problem. So if we talk about the HPV vaccine, we know that these were first licensed in 2006, and HPV vaccines are prepared using the recombinant DNA and cell culture technology. Currently, we have the bivalent Cervarix vaccine, which is effective against HPV type 16 and 18, the quadrivalent Gardasil, which is against the 6, 11, 16, 18. 6 and 11 are the HPV type which are associated with more than 90% of the anogenital ward. 16 and 18 HPV types are showing more than 70% of the cervical cancer. Gardasil 9 is effective against the 9. Apart from these 4, it also is effective at 31, 33, 45, 40, 52, and 58. Currently, this dosage schedule of this vaccine is from 9 to 14 years of age. We have to give 2 doses, one now and another one after 6 months. For 15 to 26, 3 doses, 0, 2, and 6 is recommended. The newer vaccines, the cheaper vaccines are in pipeline. One has been developed in India, indigenous vaccine, it is Servavac, and another is also in the pipeline from China. So if we talk about the various screening tests, so the newer test, basically the WHO recommends that the nucleic acid amplification test should be used, and that too the HPV DNA test. Although we also have the mRNA test, but right now currently the recommendations in general population is that we can screen them by either of the tests, HPV DNA or mRNA, but we do not right now have recommendations for using the mRNA test in women who are suffering from HPV. So Aptima is available test, RNA test, and mRNA based tests basically use the E6, E7 transcripts, and the DNA based tests, they basically use the viral genome based testing. Protein biomarkers and DNA methylation tests are experimental. We have the conventional pap smear was the first one to be introduced, and it was associated with almost 70% decrease in the cancer cases in developed one. We have liquid-based cytology and the dual screening to identify P16 and Ki60, and these are objective tests and can be utilized to triage the cases. The visual inspection with acetic acid or Lugol's has been used as a naked eye examination, and now we also have more advanced visual inspection tests which are based on AI and machine learning platform. So these tests may be utilized. What WHO recommend is to use a high performance test, HPV DNA, but some of the national programs in various countries are using cytology and VIA. So if we talk about the visual inspection with acetic acid, in this we apply 5% acetic acid to the cervix, and we look for the changes after 1 minute. It requires a little training, and it is cheaper than cytology. It has immediate results. It has, but there is a concern about quality assurance. This test has been used as a triage test, and also it has been utilized in screen and treat approach, which I'll be just discussing. So HPV DNA is the most specific and sensitive test, requires minimal training. The another advantage is that self-sampling can be done, which is more beneficial in hard to reach women. Also, cytology is a very specific test and has been used majorly. So we talk about cytology. We have the conventional cytology where we collect the cells, cervical cells, using a wooden spatula, and then we smear it on the slide, and the slide is examined by the pathologist. And liquid-based cytology, in this we take a brush and we collect the cells and we deposit them in the liquid in the laboratory. The liquid is treated and a layer of cells is then placed on the slide. Currently, the FDA approved are SurePath and ThinPrep. Either of these can be used. The liquid-based cytology decreases the number of the smears which may be deficit in the adequate cell for examination. So HPV DNA, we have discussed, it's the WHO recommended test. Here you can see Evelyn Brush and Delphi Screener. These are self-sampling devices, and this is the preferred modality of primary screening test. So if your country doesn't have HPV DNA testing, if you have the cytology and if it is quality assured, WHO recommends that till you have this system in place, you can continue screening every 3 years using the cytology. But if you have a VIA, the effort should be made to accelerate and rapidly switch to HPV DNA testing. So we have discussed this. So this is how we have to look at the transformation zone, and this is how the lesion is going to look after application of the acetic acid. It's a relatively low cost and also yields immediate results, and that's why the advantage of its use is in single visit approach. Little bit about colposcopy. Once we have a screen test positive or lady who is an HPV 16 or 18, we can do colposcopy, which is the examination of the lower genital tract under magnification, and guide. Based on this, we can obtain directed biopsy and submit them for histopathology. So these pictures I have put here. These are the newer pocket colposcopy, which maybe it is which are beneficial in the field settings. And so we use basically a sweet score after application of the acetic acid. We look at the acetovite area, we look at the margins, vessel, lesion size, and iron staining. Based on these, we give a score. If the score is more than 5, we have to, it might be pointing towards a high grade lesion requiring the treatment. So just for example, I have put this from our clinic where we see that this is the normal cervix. Then we have put a green filter to visualize the vessels properly, and then this is after acetic acid application. This is a lesion which looks like low grade lesion. This is a shady and the margins are sharp, and on application of the leucol side, it's a faintly and a patchy yellow lesion. So how we have screened, but without the treatment, it will not prevent cervical cancer. So a word about how do we treat these lesions. So we have two options. We have ablation and excision. Our excision procedure includes LEEP, laser excision, cold knife conization, and our ablative procedure includes cryotherapy, electrocoagulation, thermocoagulation, laser ablation. So let's look at what these are. So basically, an ablative therapy includes that it basically has either cryo or the thermal ablation. And once we find a person to be screen positive, we look at that, can we treat it using these modalities. So first of all, there should not be any suspicion of an invasive disease. Our colposcopy should have been satisfactory. We should have been able to visualize the entire transformation zone and the lesion. It should be a biopsy proven CIN if we are, and this is not a mandatory criteria. We can do it even for people who are screen positive. We can ablate them in screen and treat approach. So the lesion should be entirely visible. It should not occupy more than 2 quadrants of the cervix, and it should be located only on the ectocervix. It should not have any vaginal or endocervical extension for the ablative therapy to be done. So let's look at what all options we have. So we have a cryotherapy probe. What it does is once we apply it to the transformation zone and cervix, it crystallizes the intracellular water and the cell is destroyed. So we use liquid nitrous oxide or carbon dioxide, and the tissue is cooled down. It can ablate the lesions up to depth of 5 mm, and these two you can see are the newer advancement of a cryopop and a cryopen. So the success rate in a low grade lesion is almost 94% with this method, and for 84 to 86% for a high grade lesion. Thermal coagulation is the more widely used equipment, and it uses the same thing what we have seen for cryotherapy. We have got the thermal ablation probes. These are of different shapes, and this utilize electricity where we heat this probe to almost 100 to 120 degrees Celsius, and it can achieve a tissue depth of destruction of almost 4 to 7 mm. And this is the newer portable thermocoagulator which can be utilized. So similarly, the same procedure can be done using a laser, although it is not commonly used because it's an expensive equipment and training is required for handling. And so now let's talk about the excision. So if our lesion is eligible for the ablative procedure, we go for these. But if suppose the lesion is going inside the transformation zone, inside the endocervical canal, it cannot be covered by the single probe, then what we can do is we can excise using a loop wire. So as you can see, different type of loop wires are available based on the size. And what we do is we remove the transformation using the electrocautery. So this is here, either we can use a single pass method and remove the entire transformation zone. If the lesion is exceeding, we can remove it using the multiple pass method. Another excision method is conization. Suppose our lesion exceeds the capability of the loop, and it's a deeper lesion. Our endocervical curettage suppose also shows a pre-invasive lesion. A cold knife conization can be done, in which we remove the part of the cervix along with the endocervical canal. This is a WHO recommended treatment also if we have a glandular dysplasia or an adenocarcinoma in situ. Although it's a little more invasive, the risk of bleeding, infection, stenosis is more common. Especially we have to be careful in the women who desire fertility because it can lead to cervical incompetence. So a little bit about briefing about what WHO has made changes in their recent guidelines. So first of all, WHO has recommended that we should switch to a high performance primary screening test. WHO recommends HPV DNA testing either as a screen and treat approach or screen trial to treat approach. So let's discuss that. So WHO has suggested guidelines for the women of general population as well as women living with HIV. So screen and treat. Basically, screen and treat, what it means is that screen and treat in this approach, the decision to treatment is based on the positive screening test alone. Then we can subject the patient to VIA, and then we can see if the lesion is eligible for ablation, we can ablate it there itself. So it is also can be utilized for the single visit approach. However, if we talk about the screen trial and treat, we see that we have a screening test. The decision to the treatment is based on the positive screening test, which is followed by a second test, which is the triage test. So, and then the treatment is offered. So how it is different is that the screen trial and treat, it definitely increases the resources to the provide resources for another test, but also it decreases the resources for a pre-cancer treatment, and also it decreases the treatment need for the treatment in almost half of the cases. But if we suspect that the patient may be lost to follow up, a screen and treatment can also be offered based on the circumstances. However, in patients with HIV, we see that they have a higher number of women who screen positive with the HPV testing. So we have to treat them after we do a second test of triage. So this is a difference in the guidelines for these two populations. HPV DNA is a recommended testing for both. The starting age of screening for general population is 30, while it is 25 for women living with HIV. The interval as well is 5 to 10 years for general population women, while it is 3 to 5 years for the HIV women. Both can provide the self-collected sample, or a physician can take their sample. So this thing we have discussed already. Yes. So another important thing is that these guidelines have recommended that the women living with HIV needs to be retested more frequently. So what we mean by that is, suppose a lady has tested screen positive with an HPV test. So we do a triage testing for her. I'm talking first about the general population women. So if she is tested negative on the triage test, so we have to retest her after 24 months, which is 2 years. However, if the same condition is there for women who have HIV, she is tested positive on HPV, and the triage test is negative, but we need to retest them at 12 months. This is made because they have a higher number of pre-invasive lesions, so these guidelines are made in this context. Additionally, if suppose the lady has been detected to have a CIN23 lesion or an AIS, so while we follow up after the treatment, it is recommended that we retest a lady who has had HIV at 12 months, and if she is found to be negative, additionally at another 12 months, so that, and then if she is negative, then she can go the regular screening. However, only one-time testing is required if a woman is from general population. And also, if we have found that somebody has a pre-invasive lesion, she should receive the treatment within the 6 months. Okay, so the age priorities in the general population are between 30 to 49, while in the HIV it is 25 to 49 years. But if we have women in the age bracket of 50 to 65 years and have never been screened, they will also become our priority. If suppose in both the groups, if lady is 50 and has had 2 negative screening tests consequently, then we can ask her to stop the screening. So these are certain recent advances, the point of care HPV test, expert HPV and care HPV, which has been in place and can be utilized. Another few devices like AV, Gynocular, EVA Colpo, TrueScreen pocket colposcope have been in market now and are undergoing various studies. So to summarize my presentation, HPV vaccine and screening can effectively prevent cervical cancer, and we must accelerate these efforts in our countries to eliminate this cancer. HPV DNA testing is more sensitive. We do not have this thing in our setup. We must make efforts to switch to the HPV DNA testing. High-grade lesions, CIN23, AIS should be treated as soon as possible, and co-testing does not have any advantage over HPV testing alone, and even at least two times lifetime screening at 35 and 45 years of age is effective. In fact, a study from India by Dr. Shankar Narayan found that even one single round of HPV testing was adequate, and it brought down the mortality rate. So with these things, with this brief overview about HPV and cervical cancer, I would like to end my presentation. I would be happy to answer if there are any questions. And thank you for giving me this opportunity. It was wonderful to have you all.
Thank you so very much, Dr. Tomar. In the interest of time, I will go right into a very quick introduction for our next speaker, Dr. Isabella Cunha, who earned her medical degree from the Federal University of Rio de Janeiro in 1998. Between 2004 and 2006, Dr. Cunha did her residency and fellowship in internal medicine, special immunology, and HIV and infectious diseases at the Jackson Memorial Hospital at the University of Miami. She is currently an associate professor with the Division of Infectious Diseases, Department of Medicine at the University of Miami Miller School of Medicine. Dr. Cunha has published widely. She has served as principal investigators and co-principal investigators for several studies, current as well as past. She is currently the principal investigator for the anal cancer HSIL outcome research anchor study, and she'll tell you a little bit about that. It is a large multi-center NCI clinical trial on anal cancer prevention, and some of the results were reported in the New England Journal of Medicine. And so just again, in the interest of time, I will hand you over to Dr. Cunha, who will present on anorectal cancers, HPV-related anorectal cancers. So over to you, Dr. Cunha.
Thank you everyone. Let me open my screen here. Let me make sure everyone is in display. You can see the screen. Yes?
Yes, I can.
Okay,
yes.
Very good. All right. So it was the perfect sequence to the first presentation for Dr. Tomar, because all the fields from the anal cancer prevention was actually taken, or let's say inspired, not to say stolen, but inspired by the cervical cancer prevention. We thought that if we could do it for cervical cancer, why can't we do it for the anal cancer? So I want to discuss today the anal cancer prevention based on the guidelines that came out earlier this year. Actually, the CDC has just issued guidelines for anal cancer prevention. It's the first US federal guidelines for this cover this topic. So it's a new era for anal cancer prevention. It's not a common disease, but hopefully you see that certain populations can certainly benefit. Let me move forward here. I will touch, there is a lot I want to cover because my idea is for you to understand where we stand. So what's the background, why we do it, how we do it, and for the people who may be interested in setting up a program, how it can be done. So I will touch on the background of the disease, review briefly the Anchor study, because that's where we randomize patients and prove that we could do it. Then from that, it comes the guidelines from the International Anal Neoplasia Society. I will then briefly touch on the CDC guidelines that will be touching specifically for HIV, and I will talk about implementation. So I show here, just want to illustrate that anal cancer is not common in the general population. It's a little bit more common in women than in men. However, if you move to people, certain groups, you're going to see that can be strikingly high. So this was presented back in 2020. In preparation to do guidelines, we first needed to understand the risk. So the group writing the guidelines started doing this epidemiologic study that was great. There was a meta-analysis looking all we knew about anal cancer incidence. And you can see here, let me concentrate first here. If you look at men who have sex with men, and if they are HIV, look here how high is the incidence. So for the 2%, we're many folds higher here. MSM, even if they don't have HIV, their risk is high. And you can see we tried to cut the line here in 25 over 100,000. Remember the risk for cervical cancer before cervical pap smear used it to be around 30 to 35 over 100,000. It came down to 8 over 100,000. I mean, a lot of the numbers I'm going to share, they are for United States and maybe even higher in other countries who have less access to care. It came down to 8 over 100,000. So we cut the line here in 25 over 100,000 to consider that anything above that is much higher than the general population. So if you come here for a straight man or for heterosexual men, if they are HIV, their risk is also quite high. So this is not only a disease for men who have sex with men, if men are HIV. And if you move here then to women, because many of you may be very connected to women care, if they are HIV, they are more than 45, you see here the risk is actually quite striking as well. Now let's go now for the women with the independent of the HIV, if they have some sort of gynecology, pre-cancer or the high seal or cancer. And you can see here for women, so we're here in women with vulvar cancer, it doesn't matter the age, if they have vulvar cancer, look here where they are, close to 50 over 100,000, it's very high. So you start seeing that it goes even beyond HIV, correct? Solid organ transplant, they are immunosuppressed. And if you see solid organ transplant here, after 10 years, especially if they are women, look how high it is, 50 over 100,000 after 10 years of the transplant. If it's before, and if it's men, it's not as high as women after 10 years, but it's still above the 25 of 100,000. So keep in mind those groups, and then just, I think that hopefully bring awareness that anal cancer is not that uncommon in certain populations. So we use the cervical model, as I mentioned in the beginning, as an inspiration for the anal model for prevention, because when you talk about the virus, it's the same virus, And the cell lining of the anal canal is very similar. We have the transformation zone, that we have squamous cell to the columnar epithelium. And when you look at the pap smear from the anus, it looks exactly the same as the cervix. So it's the same virus, it's the same disease. Can we do the same? Correct? And we wanted to know if treating precancer or anal high seal would prove to decrease the incidence of anal cancer the same that has been done for the cervix. And before the Anchorage study, we didn't know. It was a supposition up until the Anchorage study when we were able to prove that yes, it could be done. And I will talk about this study. But before, why do we care? I mean, can we do like other cancers, prostate cancer, a breast cancer? Can we just diagnose early? But how do you diagnose early if you can diagnose before? Why it would make sense to do a prevention, especially in people at risk? You see here, if you're a localized disease, when you diagnose, the survival in 5 years is 82. For distant disease, is 34%. Remember, that's a very silent disease. It's like the cervix. By the time you have symptoms, it may be too late. So you would care to do the prevention because you would change survival. And even for the people that you diagnose cancer early, the treatment is chemoradiation, can have a very high morbidity. So we could do even better than diagnose early. We can diagnose even before the cancer happens. I just want to illustrate here. You just saw some pictures from the cervix. Some of you may do women care. So you can see here, that is an anal canal. Someone who came to see me because the provider felt he was at risk. He was an HIV gay man. He was 60 years old. He had never done any screening. And actually, when he came, he never done a screening. So he had the option to do just the PAP. But he was already in the clinic. The clinic is mainly for people to come for the procedure. And he says, no, doctor, let's do it all. I understand my risk, what we talk. And actually, when I went inside, you can see that the anal canal looks, it's very similar when you do the anoscopy, how the high resolution, that's a colposcopy of the anal canal, how similar to the cervix, correct? And then there was this beautiful lesion here. Dr. Tomar showed a lesion that is acetic acid, correct? See the whitish here, and actually that was high grade, and there was early. There was a foci of cancer. So this man with no symptoms or anything, we were able to change the trajectory of his disease because he was diagnosed very early. It was what we call CISCA, was a minimally invasive disease, and he was treated with the excision of this high lesion with the cancer within it. So just to illustrate, just for us to have some sense of what I will be talking about, and when I talk about the high grade and all, that's what we're going to be talking about. So the Anchorage study came to really prove that what we could do would be validated. And it's very similar. Again, Dr. Tomar did the presentation, so you see all the similarities from the program. So we wanted the main aim of the study was to establish that if the screening and treatment of anal high grade, like you do in the cervix, would prevent cancer. And could we do it in a safe way? Because it wouldn't justify if what we are presenting is something that people could not tolerate and it was not safe. And then there are other things that we wanted to do, collect samples, because in the cervix, we never had the chance to follow people or follow the natural history of the disease. It's not acceptable. By the time they did the studies, rapidly showed to decrease. Well, when they started the pap smear, rapidly, and then the treatments, rapidly changed the history of cervical cancer, and then it was not accepted to do natural history, but we have here the chance to do a natural history study. So we collect a lot of samples, and from this study, hopefully what we learned for anal high seal, you may apply to the cervix as well. So the schema was that we screen any patient who were HIV, men and women, they were 35 or older, and the people who would be screened with pap smear and also the high resolution anoscopy, that's the colposcopy of the anal canal, they will go to the active monitoring, the treatment arm. And then there was several sites in the United States. So it was a local for United States. We were included here in Miami. And those areas are areas with a lot, very high incidence of HIV. So we screened more than 10,000 patients with HIV between 2014 and 2021, and we found 52% of men, 47% of women, and 67% of transgender, they had high grade. We found 17 cases of cancer. This is just the screening. So from the people who were screened, remember they went into monitoring, the ones with the high grade, monitoring versus treatment. And the study, it was stopped when there were 32 cases of cancer because it reached statistic maturity, let's put it this way, where the treatment group had 21 cases of cancer versus the treatment group had 9 and the watching group had 21. So at that point, there was a median follow-up of 25.8 with 57% reduction in anal cancer. And the cancer incidence was actually pretty high in the watch group compared to the treatment group. So we felt that it was a very successful study, and we felt the implication would be, well, the implication would be the findings of that the progression from anal high CO2 cancer was very high, the treatment was effective, and we were hoping that the data would then affect the screening and treatment guidelines that we already see the reflection now. So the first guidelines came from the International Neoplasia Society. It was a process that took several years. I will move faster here. So the guidelines are available. They're online. They are available. You have free access to the guidelines. And again, for the guidelines, we based the cutoff of or this decision to the people who would benefit from the screening based on this study, and anything over 25 of 100,000 was considered to be people at risk across the different groups. Again, then we have the group A, that was the high risk, and the group B that was at risk, but not as high. Again, the guidelines are available. They're very good for anyone who are interested, but the group A, the people with very high risk, will be men have sex with men and trans women with HIV, starting the screening at 35. I will show what's the screening. Women with HIV at 45, men with HIV at 45. Men have sex with men and transgender HIV negative 45. And for the women, if they have vulvar, high seal, or cancer at any point within the first year, they should benefit in solid organ transplant after 10 years. So it has to do with the epidemiology chart that I showed in the beginning and just now. And then the group B is this group here. You can see it's here in the screen. It will be a shared decision between patient and the provider based on the different risk factors and based on the literature. All right, they can benefit, but it's not as high, especially because it will depend also in the capability to screen people beyond the group A. So the tools here, they go through the tools that you have, but I will show here what they are. So those are the tools for screening. And again, following Dr. Tomar presentation, you can see it's very similar to what we do for the cervix. You have cytology, you have HPV testing, you can do co-testing of cytology and HPV, but we want to make sure that everyone deserves a digital anorectal exam, because that may be all you can offer if you don't have the resource to do the screening. Remember, you only want to do the screening if you can do the high resolution anoscopy, that's the colposcopy of the anal canal. Otherwise, you cannot see. I just showed in the beginning a lesion who had the high grade in cancer. That's not visible to the bare eyes. So the screening is meant with cytology, HPV. If you can do, imagine if you do the cervical pap smear, you cannot do a colposcopy. There is no, you lose the idea of the screen, the treatment. You cannot even treat. So if you cannot do anything, you can always do a digital rectal exam. So that will be the diagram of how you can do the screening. Those will be the people at risk, and that's how you can do digital rectal. If you have the capability to do the high resolution anoscopy, you can do the digital rectal exam with one of the screening tests. That will be cytology and or HPV testing. If it's abnormal, you go for the high resolution anoscopy. That's a colposcopy of the anal canal. I will show you. So there are different ways you can screen. I'm not going to detain myself to the different strategies, but actually they not only mention for places where you have capability, but they also make suggestions for where you have low capability for the high resolution anoscopy. There are different algorithms, again, with pap smear, with HPV testing, with combination. All right, so this is very interesting reading if you want to set up a program. And then I just want to mention again, the CDC has just issued the guidelines. It's the first US federal guidelines for anal skin prevention. That's for HIV only, and it's very similar to for the International Neoplasia Society recommends for men and women with HIV. It's starting at 35 for gay men and transgender, and starting at 45 for the other patients with HIV. All right. Again, the goal for the high resolution anoscopy is to find and treat anal HCO. So you should only do the screening if you have the capability for HRA. If you have nothing to offer, do digital rectal exam and talk to your patients about symptoms during the visit. That is the high resolution anoscopy. You can do it in a regular room. You use my first colposcope as a GYN colposcope. You are gonna examine the outside and you are gonna examine the inside. So if you have an abnormal pap smear, that's what you would like to do. So I'm doing the pap smear. We do blind for the anal canal. That's where you want to achieve. You want to get cells from the transformation zone. I'm inserting here the anoscope. I'm showing you so you have a chance, like an idea what I'm trying to accomplish. You're gonna see it's very similar. And that is here inside already, the transformation zone. You can see here, very similar to what we look at the surface. All right. So here, let's see if you can see, well, that's the lesion here. Remember Dr. Tomar showed the lesion. You see very similar. I use the iodine. It doesn't capture the color, and that's the lesion. So what would be the challenge then now that we can screen? First, start expanding the program. Let's say some of you, maybe from different parts of the world, and you may say, well, that seems very interesting, but how can I do it? And what would be the challenge? The challenge will be the lack of people with experience in high resolution anoscopy. The learning curve for high resolution anoscopy is actually longer than for the cervix, because the anal canal, you have hemorrhoids, you have prolapse, you have folds, though developing the technique to master the HRA usually takes, there was a study done for that, usually takes 5 years, but again, you need to start from the beginning at some point and you get better doing it. There is some financial investment. You need to have the machine, you need to have a pathologist, you need to have the surgical team behind you. So there is some, you need to train. So there's some investment that needs to be made. And there is no certification process. And because someone is doing that doesn't mean you're doing it right or good enough. So at some point, the same society who issued the guidelines issued some guidelines for practice, helping people to guide people to become how they should try to strategize for their proficiency in HRA. And what you see is what they recommend, that you do at least 50 pap smears with high resolution anoscopy with at least 20 biopsies. So they set some goals. Again, if you are interested in the field, this is a very good reading. And again, this is available for free in the website, in the web. Here there is some the references here. So it guides you to the training. So take the basic. What will be the basic? Taking a course in high resolution anoscopy. There are some in Europe. I will show some. There are some in the US. There are courses online now. Observe someone who has experience in high resolution anoscopy. Take the course, watch someone, find a mentor for you, and make sure you put together a multidisciplinary team. You cannot do it on your own. You need a cytologist to be aware and know to read your smears. You need the surgeon to back you up, and you need surgical procedures. So it's a multidisciplinary team. You need the financial investment. So again, those are the ABCs, correct? Some pros from the people doing that for a long time. Build the best foundation since the beginning. Find your mentor. Have your commitments for your training. And also the ability. If you choose someone to do it, if it's taking too long, maybe there is someone else with more ability. Maybe the colorectal can learn it faster, correct? So do a course, find a mentor, start practicing. And that's how it is. It takes time to be good, but that's how we do it. That's how I did it. I took the course, I observed for a couple of weeks someone who was doing that for many years. That was actually the people who started the field. And then after that, I set up my clinic. I put together multidisciplinary initially with what we had. Later on, we done a more program that was done with more time and infrastructure, but we did initially what we have. I share with you. Those are some resources for you to get training, and you can get virtual training to the International Neoplasia Society. That's online, and that's actually excellent. And later on, people who can even come for the hands-on, but the virtual course is available. There are web rounds for people interested in the field. You can become a member to the IANS, and you can attend web rounds with a lot of education. And the International Neoplasia Society is now back post-COVID, offering in-person training. That was the in-person that we did at the end of last year. So we give the lectures, but there was also some hands-on with some models that people can train in HRA. Here, this is in Europe, in La Cunha. They have a training center there that is showing here someone, they use speaks. So they get the anal canal from the speaks, and then they use here as the model. There's a metal plate cover, but that's what is inside of their training is the anal canal. So it's an amazing center training in Europe. And then here, just sharing with you, I set up my program. Let me keep track on time. In 3 months, in the beginning, I got a colposcope from GYN. I got the gynecologist, pathologist to read my smears. I got the colorectal. We selected who can do it quick. Colorectal, they have more experience in the anal canal. They didn't know how to do the high resolution endoscopy. They took the course. They observed some people doing for a week. They put the hands on. And in 3 months, we decided that. Then when I started taking my training, it took longer because my learning curve are longer. I wanted a better machine because you are as good as your colposcope. And then we put together a team to do a prestige program. Then it took a little bit longer, but again, there are different models. And for both of them, we were able to screen and to treat patients. So we use it as an inspiration, the cervical model, but keep in mind, if you are interested in set up your practice, there are some specificities about the HRA clinic. That's a clinic here. Again, it's in the room. You have a scope, but you see my scope now is different. It moves around. I need some mobility. And also I have a picture system so I can teach people, and also I can see what people were doing. So that's important. And also this is the other view of the room. So nothing complicated. My big investment is this because it makes a huge difference. All right, here I was the same patient years ago with my old scope, and now with my new scope, and also my technique, I could open better the canal, but you can see that it makes sense if you're gonna do a clinic, if you have the chance to invest in a good equipment. You see here how the picture system is important. The patient in 2016 with high-grade lesions came back in 2023, and because of the picture, I could see the lesions regress spontaneously. So how the system can, you may not have that to begin with, but if you can, that will be great. Image capture system, you can see here how nice it is. People can see what I'm doing, and I can also see what people are doing for the teaching. That's all you need. That's the table. I just wanted to view. That's nothing complicated to put together for the exam. I use the tisular like we use in the cervix. And for when we talk about treatment, Dr. Tomar mentioned ablation. That's what we do most 90% of the time. You can apply TCA, you can apply some imiquimod, but most of the treatment effectively is ablation. This is the same machine that dermatology use to ablate some skin lesions. Those are all the medications you need. Again, most of the medications you have readily available in any medical center. And again, this scope is the most essential, and you want something that can move around. So the program, for you to set up a program, if you're interested, you need to come with an algorithm that will have to do with the capacity that you have. So from the guidelines, you can see who should be screened within your capacity. You need to prioritize, get your cytology pathologist involved in your colorectal surgeon. The guidelines are out. Implementation requires a program to detect and treat the anal cancer. It's a good time to start. think about your algorithm, the population you want to screen, and the resources you need to have. And I'm going to stop here. And I guess we have some time. Maybe we have some few minutes for questions.
Yes, thank you so very much, Dr. Isabella. That was another great presentation. And so, colleagues, I encourage you to submit your questions to Dr. Tomar and to Dr. Cunha. Thank you, Dr. Tomar, for really taking us through a comprehensive presentation on cervical cancer. While I speak, colleagues, please go ahead and submit your questions. We'll take them as you submit them. And again, thank you, Dr. Tomar, for presenting very comprehensively on cervical cancer, looking at the global burden, the risk factors, pointing out that 16-18 are the high risk for cervical cancer, talking us through some of the epidemiology in terms of HPV prevalence, etc. Walking us through the approaches, the screening and treatment, WHO life course perspective, our life course approach to the management, screening, diagnosis, and treatment, sharing with us the 90-70-90 for control for 2030, and then finally touching on WHO recommendations and sharing with us some of the new advances in technology. So very comprehensive presentation from Dr. Tomar. From Dr. Cunha, thank you so much for sharing on anorectal cancer. And so indeed, so much commonality between cervical and anorectal cancer in terms of, you know, the pathology, in terms of the screening, diagnosis, treatment, technology, and for taking us through the ANCHOR study, which I think was a really important one in terms of the whole area of prevention and treatment for anorectal cancer. Quite interesting in terms of how you've set up your clinic and the resources that are needed to set up a clinic like this. I think a lot of us may have much of what we need in country already, but I think that it was good to share that as well. We have a question from Professor Figueroa from the University of West Indies, who is saying, we need to get all of our pre-pubertal boys and girls vaccinated for HPV, that the coverage is too low. And so I want to concur with Prof. That's a point that we have discussed in preparing for this webinar. But I wonder if either one of our presenters may want to add to Prof's comment.
And I think, well, I don't know if Dr. Tomar wants to comment. So just one from the anal cancer prevention, you know, primary prevention is also preferable. So we are behind because a lot of the people now at risk, they haven't had the chance to be vaccinated, but the message to vaccinate boys and girls will be very important for the future also, not only for the cervicals, but now probably for the ones who are not aware, also for the anal, correct? So that's actually very important also for the anal cancer prevention.
Yeah, thank you, Dr. Cunha. Any comment from you, Dr. Tomar? Okay, all right.
Can you hear me?
Yes, yes, we can.
Yeah. So HPV definitely it is going to be if the boys are vaccinated, it's because it also has the herd immunity. So once the boys are also vaccinated, it's going to cover a number of cancer, and already the vaccination for boys has been introduced in many countries. Australia has been the first one to introduce for boys as well. So I think it is going to decrease the burden of disease a lot, and especially for the high risk people with, you know, MSM group and all. So it will have more efficacy in this group.
Okay. Thank you, Dr. Tomar. I will share one of the poll, the responses from the poll. Will your partner be protected from HPV infection if you're vaccinated? And we have 54% of the person saying yes, 46% of the person saying no. So can I ask our presenters to react to the results of the poll, please?
So yes, the partner is also protected. So basically, if you are in a monogamous relationship, so definitely it is. And also the probability of, because it's a sexually transmitted infection. So if you are vaccinated, and these vaccines, if you are sexually, you have not started the sexual activity and you've got the vaccine in the younger age, and you have got it before commencing the sexual activity, these are almost close to 90%, 100% rate. So yes, definitely your partner will be protected.
All right. So we have one comment from, let me just check. We have one comment from, one second for me, from Marianne, who is asking if there's an age limit for persons who can have the vaccine. I think you shared that, Dr. Tomar. Maybe you can do a repeat for us.
No problem, that's all right. The HPV vaccine is basically approved up to 45 years of age. So if it is like the WHO recommends that, in the age group 9 to 14, this is the one which we have to target the most. 15 to 26 is the catch-up vaccination, and 26 to 45. It is also after, beyond that also we can actually vaccinate, but then if the people are already infected, the efficacy will go down. They should know that. But if you have but there will definitely be another benefit, that they will be vaccinated against the other HPV types which they have not yet infected. So this is another benefit. So if that can be offered to them, but it is approved. But in the guidelines, we have from 9 to 26.
Okay, all right. Thank you, Dr. Tomar. Just a comment as a follow-up from Professor Figueroa's question. We have a comment from Mary Ann that's saying persons do not want to have the vaccine because they think it would encourage their children to go out and have sex. And I think it's a common perception that we have in the Caribbean. I don't know, it's probably similar elsewhere.
Yes, it is, but there are studies also to show that this may not increase. But with the proper education and promotion, I think it should be definitely be promoted.
And another thing for that, when you argue with this misconcept, is that people vaccinate babies for hepatitis B, that is primarily a sexually transmitted disease, and that's not an issue, correct? So if we vaccinate for other sexually transmitted like hepatitis, why wouldn't we vaccinate for the HPV? The hepatitis doesn't change the sexual debut age or nothing like that. So I think that we be also prepared, or prepare people working with us to be able to relate to the question, to have a strong answer so people can understand, correct?
Yeah, I think that's an excellent point. I think how we communicate and what we communicate is also really important. I wanted to share this this poll, the results, and get your thoughts on any additional comments to what you've shared in your presentation on this poll.
Yes, because if you look at the vaginal cancer, the vulval cancer, so those even 16, 18, 31, they are implicated for causing these cancers. So if you have got the vaccine, you will be also be protected against the other.
Yeah. Any thoughts from you, Dr. Isabella?
I don't know if I can see the poll, but what was the question? If the HPV prevents against the other cancers, or and the head?
Right.
HPV,
And we have
correct.
72% of our participants are saying yes and 28 says no.
For protecting the partner, correct?
No, this is about protecting against other
Correct. Yes.
cancers.
Okay, fine. Because I cannot, I don't know why I cannot see the book. So that's correct. You will protect against the other, HPV diseases, infection, dysplasia, and cancer. We do have the study. We don't have for head and neck, so we extrapolate. But there is a study for the anal, correct, with the boys and girls, and actually how the approval for boys came from.
Yeah, thank you. We have another comment from Ms. Valerie Wilson from Caribbean Med Labs Foundation, who's saying that another objection to the vaccine that people would raise is that most of our common types of HPV are not present in the vaccine. And again, I think it goes back to the point that both of you made that, we have to be very focused in the messages that we're sending, what information we're providing. But I don't know if you have any comment on Valerie's observation.
No, I think exactly what you say. You need to be prepared, correct? Yes, you may not have. I mean, here in the United States, we have the luxury to have the 9 types in the vaccine. But if you are not, they're going to say, well, the great majority of the cancers are caused actually by 16 and 18, and mainly 16. That's actually is included in the vaccine, correct? So we need to be prepared to answer. We need to be prepared to say, you may not be thinking about it, but can you think how distressing it is to have you go to your doctor and be told you have HPV, you have a precancer, we need to treat. This is very distressing for women. And also cancer, we can say also the concept of you preventing even before it happens. No other cancer you can prevent before it happens like you can with HPV. That's something very unique that you have with the vaccine. So I think you need to be prepared to answer those. We know that they are common. Those barriers have been identified before. So I think if you're talking with the population you want to vaccinate, I think you need to be prepared to answer those questions. And if you are, most people, at least they start thinking about it, if it's something that's reasonable.
Yeah. Awesome. Thank you, Dr. Cunha. I think that's on that note, we will close today's webinar. I would like to extend our deep gratitude to our presenters for investing their time and resources to share with us on this really very important topic. So thank you very much, Dr. Cunha and Dr. Tomar. I think both presentations were excellent, comprehensive and excellent. Before I close, I want to take the opportunity to thank our collaborators for this specific webinar. Dr. Sumit Mitra, the President, Dr. Kuldeep Singh Sachdeva, CEO, and Mr. Mario Ulate Solano, Consultant, all of MUL Biodiagnostics. Thanks also to Mario Richard Dell, the Business Unit Manager, and Ms. Claudia Rashai, Sales Marketing Coordinator, both of Western Scientific Company Limited. Colleagues, I want to thank you all for being with us this morning, for submitting your questions. If you do have any additional feedback, observations, need any clarification, do email us. And please watch out for our next webinar on viral hepatitis. This will be on August 2nd. So in another few days' time. And with that, thank you all very much. We will email the presentations to you, and do have a good day, everybody. Thank you.
Thank you for the opportunity. Thank you.
Thank you very much.